Thank you for the opportunity to participate in CVI 2020. I congratulate the organizers on putting together this great symposium. My topic for this today is to discuss exercise and medical therapy for aortoiliac peripheral artery disease. Is this a reasonable first-line treatment option? Here on my list of conflicts of interest, you'll notice that I'm a part-time employee of Boston Scientific. When you care for patients with claudication, you choose what you believe will make patients feel and function better. So here's a patient with a severe proximal right common iliac artery stenosis. The options include an endovascular approach versus exercise therapy. I think we all agree that medical therapy is critical to the management of all patients with peripheral artery disease. That includes modification in lifestyle to reduce cardiovascular risk factors, antiplatelet therapy, and then of course for symptomatic patients, revascularization or exercise therapy. In peripheral artery disease with obstructive disease, there is a significant gradient that develops across the stenosis, which reduces distal perfusion to the limb. It results in a mismatched oxygen supply and demand and leads to high oxygen stress. Exercise has many benefits to improve the functional status in patients with PAD. This can occur at the macro and microvascular level as well as at the cellular level. There are metabolic and mitochondrial abnormalities that occur in patients with peripheral artery disease, which also result in impaired exercise function. Exercise training, in fact, has been shown to be the cornerstone of treatment for patients with claudication. This Cochrane review of 22 randomized clinical trials demonstrated a marked reduction in pain-free walking distance and maximal walking distance just with exercise therapy. In the 2016 multi-society guidelines document for the management of patients with lower extremity peripheral artery disease, supervised exercise therapy obtained a level of evidence A recommendation with certain guidelines, including the fact that this would take place in a supervised environment in an outpatient facility or hospital. Intermittent walking is the treatment modality. This can be done alone or within a cardiac rehab program, which is the most common scenario in the United States. This is supervised by someone who knows how to do this and is trained in supervising exercise therapy for claudication. We recommend sessions at least 3 times a week for a minimum of 12 weeks at 30 to 45 minutes per section. Patients would walk to moderate to maximal claudication, alternating with periods of rest, along with warm up and cool down. As a result of this, in February of 2017, after many years of advocating for this, the Centers for Medicare and Medicaid Services did provide support and reimbursement for supervised exercise training programs. So why not offer exercise as the sole initial treatment for patients with claudication? Well, this cartoon tells it all. Most patients really don't like this because it's uncomfortable. It's not a quick fix. It takes weeks to months to notice improvement. And in fact, the data does suggest in this more updated Cochrane review in 2014 that the benefit is seen at 6 months, but not at 3 months, which shows the importance of a 6-month protocol. The benefit is clinically significant, but it does not normally distribute across all studies. So not every patient will notice similar improvement. We also know that supervised exercise is better than unsupervised exercise up to 12 months. And so guidelines documents have said that individuals with intermittent claudication who are offered the option of endovascular or surgical therapies should be provided information regarding supervised exercise therapy and guidelines-based best medical therapy. Now, there have been a number of clinical trials that have evaluated exercise versus endovascular therapy for patients with aortoiliac occlusive disease. The CLEVER trial, published now a decade ago or so, an NIH-sponsored randomized clinical trial, compared optimal medical therapy to supervised exercise to stenting. Unfortunately, the combination arm of supervised exercise and stenting was not included due to poor enrollment status. And in the CLEVER study, stenting offered improved functional ability on measured treadmill walking times, but symptoms actually feel better with exercise, according to patients. The real question is, does stent plus supervised exercise add incremental benefit? In the ERASE randomized clinical trial, looking at supervised exercise therapy with or without endovascular therapy for both aortoiliac and femoral popliteal disease, these were patients who had stable claudication and were randomized head-to-head. They were followed for 1, 6, and 12 months, and you'll notice that in people who received endovascular therapy plus supervised exercise, they had a statistically significant improvement in walking distance at all intervals, 1, 6, and 12 months, compared to those who received exercise alone. And in pain-free walking distance, similar findings at 1, 6, and 12 months of endovascular therapy plus exercise over exercise alone. In addition, quality of life surveys, in particular the VascuQual study, demonstrated in the ERASE trial, again, superiority of endovascular revascularization plus exercise at 1, 6, and 12 months compared to exercise alone. Finally, a nice benefit here was the freedom from secondary interventions was statistically better in people who received endovascular therapy plus exercise as their initial randomization arm compared to exercise alone. And so it's clear that supervised exercise therapy is the first-line treatment for claudication. But have I convinced you? So if you saw a 65-year-old person with this anatomy and significant buttocks claudication and could get these results in an outpatient setting, which would you offer? Again, thank you very much for the kind opportunity to participate in this symposium.